And there is no obvious bleeding, right? There is no obvious bleeding in this patient, but the preference is still low. I will go with stent.
So,
saying that if platelet count is below 1 lakh, there is more risk that we
yeah.
injure.
So some people,
Yeah, 40, 50, but the patient is 70, so I will go.
yeah, so less than 20, absolute no, right? Usually, that's what we say. And then less than 50, concern for bleeding. 50 to 100, you dance around. So I said, okay, let's do this. Let's call the hematology oncology. Most of the time, hemo, particularly patients in a CCU, they are useless. They will give you a cause for thrombocytopenia. There is nobody here from hemo. They ask me clopidogrel or Brilinta or balloon pump. Patient has any device. They are on HIT and they give you a whole differential. Really doesn't help us. But you need to tease out the time of the drop in platelets and which one fits the best. Here, stable CAD, I get a consult and they said that these platelets are good, platelet aggregation is not bad. So I said, okay, so let's prove it. So I gave 2 weeks of gap and then brought back and then did the rotor PCI and then good. I remember I was with Morton. Morton says, if you need me, call me. I said, no, I'm not going to call you. I did the rotor and then everything good. I already know there was no power in the bleeding. So sometimes it may be okay to just give a dry run with the dual antiplatelet and to see.
When you are doing after 2 weeks of dual antiplatelet?
Because during that 2 weeks, I have one problem, that whether the bleeds or not. If it bleeds, then I will say to the fellow that it's not worth going for a long-term gap because he may not tolerate long-term gap. I would argue for edema. He did not want the surgery. Okay, so, but I think we all agree that following the PCI for at least 1 month or 3 months gap, we call it almost like mandatory. I don't know, I would be brave enough to give a single antiplatelet right from day one. Any comment from you guys?
I have one question regarding the stent. Any type of stent regarding shorter antiplatelet?
So the best data we have is the teen starts, the newer generation states, where we know from the OCT imaging trials that usually 1 month, 3 months, many have completed the endothelialization nicely. So it is not diabetic, not long stents, not overlapping.
Yeah, your stent was perfectly well approached. I think that was very. Stent was, I think, that was perfectly done. So in this case, 1 month, I think that is.
Yeah, we did not give long-term gap. We gave 3 months actually. Didn't have any bleeding and then good.
Sir, one patient, we did a PCI, and the next day when the patient was attempted for catheterization, he starts bleeding. And patient was on ticagrelor and aspirin, but he continued to bleed. And then we decided to call for urologist opinion. They said give the bladder wash and if possible, stop the antiplatelet. So what we did, we switch over to the clopidogrel with the loading dose. We stopped ticagrelor and also we stopped the aspirin. And by this, at the keeping following him in the hospital for 7 days, his urine color normal. Then we sent the patient with a single antiplatelet and we asked him to come back so that we can restart the dual with the challenge.
I think that what we do, like that's the whole point of discussing, that we try to consider balance. When we have a clinical situation, we balance the risk of the bleed and the benefit from not having an ischemic event. So that's balance, we have to use our judgment. But the theme is also that if we find a source, go after the source. take care of the source, and then continue that as you need it. So this patient, complex PCI before, and then this is similar situation. Had that before, and then he was getting angina, and we did the wrote on the CERC, LAD, and then left brain bifurcation stent. He was having problem. He was having angina when he was feeding the horses as he tries, but now angina free, happy, and then admitted with hemoglobin drop. So he was turned down. He was turned down because his chest was like this. So I can't blame the surgeon. And look at this, that his hemoglobin dropped, and then what happened? The communication lab, and then DAPT was on board. They stopped. So you need to also educate your hospitalists and your colleagues that when this happens in a complex procedure, you need to call us. Don't just stop. And then stop, and the endoscopy was not done for a few days. So these are the important things to pay attention to. So we talk about procedures, but there's a lot of things after the procedure. This one, I think Ramesh is sharing a similar experience. Patient with uterine bleeding, and then troponin rising, and sometimes it's a problem. And then we said to stop the menorrhagia, looks like the uterine bleed. And then we said, okay, you can take care of this hysterectomy. Patient is okay, but the OBGYN says no surgery. So what do? You'll have to call your interventional radiology, and then we did coil embolization, and then we did PCI, and then after it was fine. Stroke is a big problem. And the stroke and the question about that. So first of all, I don't give routinely DAP for a stroke patient unless okay from the neurologist. Because I ask the neurologist, who is first? Is the patient, why the patient came in first? Stroke or MI? If the patient came in for a stroke and then troponin rise, that could be because of a variety of reasons. It could be coexistent MI, possible. It could be stroke heart syndrome, Takotsubo, possible. It could be just some hemodynamic changes that happen with the stroke. Who knows? And we have plenty of data that stroke heart syndrome, not all may be classic type 1 MI. So why rush? However, it is a different scenario. The patient came in with anterior MI, 2 days later had a stroke. Then something happened after the MI. So then you need to collaborate with the neurologist. But whatever it is, large ischemic stroke, there is a potential for hemorrhagic transformation. So I had this thing that large hemorrhagic is dense ME, and the neurologist said heart is more important to whatever you want to do. I said buy time. That night, patient had a hemorrhagic transformation, coning, and then got intubated. I said, no, you need to take time. One of the things that I've found very helpful is the echo and the contrast echo. You may see, and we have published this, that echo can be a good guidance to identify whether there is the stress cardiomyopathy. You can see typical apical ballooning, and that can be classic apical, mid-ventricular, or reverse Takotsubo. So that will give you time. Now, what about this patient coming with acute coronary syndrome, hemoglobin low, and we talk about this, and we were talking yesterday that hemodynamics and what do you want to do? This is an old case in the middle of the night. We did not have Impella then, but what do you want to do? And the surgeon says, Yeah. Surgeon said, do whatever you can do because I don't have any anesthesia. Some kind of excuse. So, I then take a minimalist approach. Actually, we had one case I was looking for when I started first in Bangladesh, then maybe 2006, 2007. After left main, there is nothing. So if patient is 50 years old and the blood pressure dropped to 50, and my tech who came with me was asking me, are you going to do something? We had nothing at that time, no balloon pump. I said, okay, pray for me, I'm wearing both. And then I stented the left main LAD and then dilated the cert, keep it minimal. Next day, patient was fine, no problem. So what Ramesh was saying that you have to do whatever you need to do in acute situation, you know. So we did bailout quick and then. So the question is, what do we do about dual interplated on this patient? Acute, I think, is a different ballgame, and we need to take care of this. And we may talk a lot of things, but you are listening to us, you are seeing this, but in acute situation, I find it now more difficult to take care of this table because all this burden on us to prove ischemia, to prove appropriate criteria to do stable coronaries. But acute coronary syndrome, I think we still win. You know, across board, the PCI performs much better than going to surgery. You guys agree with that? So we need to take care of these acutes, and we'll be doing some more practical cases, EKG based and acute coronary syndrome, maybe next year with this guy. So I'll stop there, and if you have any questions.
Thank you very much, Hafiz sir, for your excellent cases and interactive discussion. Madam, please. Okay.
Yes, I just want to add something, Hafiz. Maybe you're aware of a trial that we were also part of, National Heart Foundation. So that was the Master DAPT trial. Okay, so in that trial, it was shown unequivocally that if you give an abbreviated DAPT regimen to a high bleeding risk patient and you implant an ultramaster stent in them, you in no way increase their ischemic risk, but you safeguard them from the bleeding risk. So, maybe choosing your stent wisely when you're dealing with a potentially high bleeding risk patient and you have to put in a stent, maybe choosing your stent which will give you the flexibility of, lowering your DAPT at will, that does help.
I agree more. There's a JACC publication you saw that the complex PCI, the outcome actually is worse. So we need to find a sweet spot about the prevention of ischemic episode and the risk.
Absolutely. So you need to find the sweet spot, and in that there was no exclusion criteria, like even acute coronary syndrome patients were being taken, including ST segment elevation MI, and they showed that you could stop your DAPT if required.
And we are learning a lot actually from the COVID time, and I have the whole set about the acute coronary syndrome COVID. We are participating in active study with the COVID, still ongoing, and we are learning a lot about the DAPT and then the implications of DAPT. It is not fully out, but we will be learning more about this. Thank you.
I have one question to Acharya. All about that hemorrhagic stroke. Patient angioplasty done at morning, at night patient develop hemorrhagic stroke. So what should be the anticoagulant in this patient?
Tough situation. So I usually collaborate with the neurologist and see, because sometimes the stroke, ischemic stroke, and I'm not a neurologist, I have to ask my wife, that the punctate hemorrhage versus frank hemorrhage. Sometimes they say, okay, I said, can you look at the MRI yourself? And then tell us whether we should be okay to use the DAPT or not. But if it is a frank hemorrhage, then my experience, I can tell you this, if it is dense hemi, like to low power, 0.5, and I tell the fellows, please learn how to examine, at least cross the neurological examination. If it is dense hemi, all bets off. If it is loss of consciousness and dense hemi, even worse. Then I try not to listen to neurologists at that time.
Thank you very much, Professor. Now the turn of Professor Pedilatinisa Malik. You know, captains usually lead from the front line. So Madam is doing all the captaincy of Heart Foundation, staying in the front line.